Hi everybody, and welcome to our module on hypersensitivity disorders. Let's start by talking about some of the terminology used to describe some forms of allergic skin reactions. When we say that a patient has urticaria, that's the same thing as saying the person has hives. The two terms mean the same thing. And urticaria is a specific type of allergic skin reaction we'll talk about in a minute. It's usually itchy, and on the skin you see raised wheals, and you can also see angioedema. Angioedema refers to deep mucocutaneous swelling. This is a picture of a child here with angioedema around her eye, and angioedema is often a component of urticaria. So now let's talk about urticaria. This is a classic allergic skin reaction. Some people will develop urticaria when they eat certain foods. Some people will develop it as a reaction to medications. In some cases, the trigger can never be determined. It's usually caused by mast cell degranulation. It's an example of a type 1 hypersensitivity reaction where an antigen binds to IgE antibodies on mast cells and histamine is released. And I've bolded histamine because it's high yield to remember that this is a major player in the cause of urticaria. In terms of the skin, it's high yield to know that there are no changes to the epidermis in urticaria. This is entirely a dermal problem. Remember, your blood vessels are located in the dermis, so what happens in urticaria is those blood vessels become leaky, and that leads to dermal edema. In addition, lymph vessels will dilate to drain the fluid from the dermis, and so the combination of dermal edema and dilated lymph vessels leads to urticaria. And this is a picture of urticaria on the screen here. All of these skin changes are being caused by dermal swelling, and so you have these raised wheals like seen in this picture here, and it's very itchy. Those are the classic findings in urticaria. Urticaria is usually an acute condition that is self-limited. Remember, it's a type 1 hypersensitivity reaction, so it occurs quickly and acutely following exposure to a trigger. It then usually wanes over time and resolves within a few days or weeks. And you can treat urticaria with drugs, and the drugs that are used should make sense to you. So antihistamines are used to block the effects of histamine, and steroids are used to knock down the immune response. In many cases, urticaria occurs by itself, but it can also occur as one component of anaphylaxis. Anaphylaxis is a systemic and potentially life-threatening type 1 hypersensitivity reaction, and most people who have anaphylaxis in response to some trigger have urticaria as a component of that anaphylaxis. But in addition to the skin findings of urticaria, they will have wheezing from bronchoconstriction. There can be swelling of the mucosa, especially the lips and the tongue, and this can be life-threatening. There can also be hypotension and syncope. These are features of anaphylactic shock. Now let's talk about atopic dermatitis, which is also called eczema. This is a chronic disorder, so different from the acute disorder urticaria, and it involves flares of skin findings followed by remission. This is also a hypersensitivity inflammatory disorder. However, the pathogenesis is complex and poorly understood. It involves T cells, it involves cytokines. They aren't going to ask you about this on your boards. You don't need to know what type of hypersensitivity reaction it is, and that's because the researchers who study this condition still don't fully understand. Usually eczema is extrinsic, meaning it's a reaction to some environmental antigen, although that antigen often cannot be determined. There is a less common form which is intrinsic, an intrinsic response of the body against the skin. Eczema usually occurs in children, and it presents as a red, itchy rash on the skin. We'll talk more about that in a minute, but this is a picture of a child who has eczema on the forearm, and the child has been scratching it, so there are scratch marks present. There are a couple of special features of eczema that you need to know for your board exams. Over 80% of patients with the extrinsic form of eczema have increased levels of serum IgE. 70% of patients with eczema have a family history of atopic diseases. Atopic diseases are diseases like asthma and eczema and allergic rhinitis. So most children who have eczema will have a parent or siblings who also have these allergic atopic diseases. And among children who develop eczema, most of them also have some other atopic disease or eventually develop some other atopic disease like allergic rhinitis or asthma. This is called the atopic march, as children march from eczema to asthma to allergic rhinitis and develop all of these inflammatory reactions. So eczema can occur anywhere on the skin, but there are some classic locations. In babies, it classically develops on the face and the cheeks and the scalp. This is a picture on the screen here of a baby with eczema. You can see that there's redness all over the temples and the scalp. In addition, there is flaking of the skin. In children and adults, it typically leads to development of plaques. These plaques are often thickened. That's referred to as lichenified, and they classically occur at the skin flexures. So they're going to be at the antecubital or popliteal fossa. This is a picture of a child here who has eczema at the level of the knees. Now let's talk about contact dermatitis. This shares some clinical features with eczema, but it is a localized reaction to an area of skin contact with an allergen. For example, if you look here at the bottom right side of the screen, this is someone who obviously had a Band-Aid or some adhesive attached in a square to their skin, and they've developed an allergic reaction at that one particular spot. The same can be seen in this picture on the left side of the screen. And this form of dermatitis is a type 4 hypersensitivity reaction. Many forms of allergic dermatitis are type 4 hypersensitivity reactions. Urticaria is not, and eczema is poorly understood, but all the skin hypersensitivity reactions we'll talk about in the rest of this video are type 4 reactions, and that includes contact dermatitis. Some of the classic causes are irritants like poison ivy. Poison ivy is a classic example of contact dermatitis. Some people who wear jewelry that contains nickel can develop contact dermatitis, and some people have this reaction to laundry detergent, so they will develop dermatitis at areas where their skin touches their clothing that has lingering degrees of laundry detergent on it. The treatment is to remove the irritant. That's the easiest way to treat it, but if that doesn't work, or if the dermatitis is severe, steroids can be used, and especially in some patients who have severe cases of poison ivy, steroids are necessary to limit the itching and the skin rash. So now let's talk about drug rashes. So some patients who have skin reactions to drugs will develop urticaria, like we talked about earlier. Very soon after they take the medication, they will have a skin eruption that is itchy. It consists of wheals and dermal edema. Those patients are having urticaria. But many other patients have a delayed development of a drug rash. This is called a non-immediate reaction to the drug. It's best described with some penicillin antibiotics. These patients develop a rash days or weeks after starting the drug. The rash is maculopapular. Sometimes it's itchy, but it can also be not itchy. And there are no signs of systemic symptoms or systemic reaction to the drug, things like fever or wheezing or joint pain. So what these patients are having is a type 4 T-cell mediated hypersensitivity reaction to the drug. And the way you know that is that it occurs days or weeks later. There's no way this is going to be a type 1 hypersensitivity reaction if it starts 2 weeks after the patient took penicillin. That is a non-immediate drug rash, and these are actually common, in fact in many cases more common than urticaria after taking a drug. And if you want to know more about this, I've put a listing of a paper down at the bottom of the screen. Drug rashes are relatively common. What's less common but much more dangerous is the Stevens-Johnson syndrome. This is a severe skin reaction. It's also a type 4 hypersensitivity reaction. In addition to the skin, it may also involve the mucous membranes, like those inside the mouth or in the genital tract. It is usually triggered by drugs, so it is also a form of a drug reaction in most cases. And the hallmark is necrosis of the epidermis. Basically what happens is patients lose their epidermal layer of their skin, and that's why this is so dangerous. When you lose your epidermis, you're prone to infections and you become dehydrated because you lose water, and that's how people can die when they have Stevens-Johnson syndrome. Also in this disorder, you can sometimes see Nikolsky's sign. This is when the skin slips off with a gentle tug, and this can happen anytime layers of the skin are becoming detached. In this case, the epidermis is becoming detached from necrosis. You can also see Nikolsky's sign in staph scalded skin syndrome, which occurs in children. You can also see it in pemphigus vulgaris. The way Stevens-Johnson typically presents is first with a prodrome. This usually occurs 1 to 3 days before the skin findings. The patient will develop a fever, sometimes they will have a flu-like malaise, and often they think they're coming down with the flu. Then the skin lesions will begin classically on the face or chest, and it's high yield to remember this so you can recognize Stevens-Johnson in a board question. From the face or the chest, the lesions spread symmetrically. The patient can first develop red, tender skin. Remember, the epidermis is undergoing necrosis. These lesions can progress to vesicles or bullae, and eventually there will be sloughing of the skin. That's the hallmark of this disorder. Shown on the screen is a picture of a man with Stevens-Johnson syndrome, and you can see all these patches on his face where the epidermis has fallen off. And like I said before, the mucous membranes, like those in the mouth or the genital tract, are involved in 90% of cases. When Stevens-Johnson syndrome affects more than 30% of the skin, it's called toxic epidermal necrolysis. This is a severe form of Stevens-Johnson where more than 30% of the skin is involved. If it's less than 30%, then it's called Stevens-Johnson. Both of these disorders carry a very high mortality. The mortality for Stevens-Johnson syndrome is up to 5%, and for toxic epidermal necrolysis, it's greater than 25%. And this is all because of losing your epidermis, becoming prone to infections, and losing water because you've lost the skin barrier. Our last hypersensitivity disorder of the skin is erythema multiforme. This is a skin disorder that is a hypersensitivity reaction to infections, most commonly in 90% of cases. It is classically described as following herpes simplex virus infection. This is the most common trigger for erythema multiforme. Less common is mycoplasma pneumonia, especially if it occurs in children. And there are a number of other triggers that have been described. For board exams, it's usually going to be someone who has herpes simplex, but this disorder has also been described in patients who take sulfa drugs or NSAIDs or the anti-epileptic medicine phenytoin. It's also been described as triggered by cancers and some autoimmune diseases. The pathogenesis of this disorder is unclear. Most of the data come from the herpes simplex related cases, which, as I told you, are the most common. From those data, this is considered to be a cell-mediated type 4 autoimmune reaction that is triggered by viral antigens in the keratinocytes. And remember what I told you earlier, most of these hypersensitivity skin reactions are type 4. There are just a few exceptions like urticaria. Erythema multiforme gets its name because it involves red lesions, that's why it's called erythema, and the lesions have many different forms, that's why it's called multiforme. Patients with this disorder can develop macules or papules or vesicles or many different forms of skin lesions. The lesions are usually similar for one particular patient, but they differ between patients, that's why it's called multiforme. The hallmark of this disorder is the target lesion. This is a picture of one right here. A target lesion has a dark, dusky central area and it's surrounded by rings. If you look closely at this picture, it's dark in the middle, surrounded by a lighter color ring, and sometimes there can even be multiple different colors to the rings. So patients with erythema multiforme can have lots of different lesions, but usually somewhere among those lesions you will find one or more of these target lesions, and especially in a board question, they're going to describe one or several target lesions to let you know this is a case of erythema multiforme. This disorder usually has a symmetrical distribution, and it classically starts on the extensor surfaces of the acral extremities. That's what you'll read in your textbooks. And what this means is it starts on the backs of the hand and feet. And this is in contrast with Stevens-Johnson syndrome. Remember that Stevens-Johnson syndrome can also follow an infection or an infection that was treated with a drug, but Stevens-Johnson will start on the face. This will usually start on the hands or feet, and it will be symmetrical, but then it will spread to the center of the body. This is called centripetal spread. And it may involve the mucous membrane, so just like Stevens-Johnson syndrome, there can be involvement of the mouth, potentially even the eyes or the genitals. These mucous membranes will develop redness, that's erythema. There can be painful erosions, and sometimes there can even be bullae. So the typical case is going to be a patient who develops an acute eruption of oral or genital herpes simplex virus infection or some other trigger. The erythema multiforme skin eruption will occur a few days to 2 weeks later. The lesions will then evolve. Like I told you before, they'll spread to the middle of the body over 3 to 5 days, and they'll resolve within 2 weeks. This disorder requires no treatment in most cases. In rare severe cases, it's treated with steroids or some other types of drugs. And that concludes our video on hypersensitivity skin disorder.